Hello friends, today I will talk about insulin, types of insulin. First is the disclaimer. This video is made for educational purpose only and there is no endorsement for any brand or a company. Insulin is categorized as human insulin and insulin analogs. The human insulin is very similar to endogenous insulin except that it is produced by recombinant DNA technology. Among the this human insulin, we have regular insulins, NPH insulin, insulin U500, regular insulin, and the insulin analogs. These are the insulin in which some modifications are made in the structure of the human insulin. For example, addition, replacement, or deletion of the amino acids. These insulin analogs are further categorized as rapid acting insulin analogs, basal insulin analogs, and biosimilars. Biosimilars are basically these are the biological agents and very cheap. For example, insulin glargine. Whenever we inject insulin in the subcutaneous tissue, it first enters the capillaries, and to enter into capillaries, it has to be in monomer or dimer form because monomer forms they are rapidly absorbed into the capillaries in the subcutaneous tissue. If the insulin preparation is in the form of hexamer or polymer, then it can't be made transferable to capillaries and its absorption becomes slow. Uh, Whenever we prepare an insulin, there are some problems with the insulin. The main problem is whenever we give insulin to a patient, there is a problem of physiological pattern of insulin secretion because whatever exogenous insulin we give, they do not usually match with the physiological pattern of insulin secretion. Normally, in all human beings, some amount of insulin is secreted by the beta cells of the pancreas irrespective of the meals, and this is called basal secretion, and this is important to keep the check over hepatic gluconeogenesis in the fasting state. As we know, in fasting state liver produces glucose in a very high quantity, and to suppress this insulin will be produced in a low quantity to keep a check over it. If we take the food or snacks, the glucose in the food will stimulate insulin release, and this release of insulin is called meal related insulin secretion or prandial secretion, and this will come to normal after some time. So there is some amount of basal secretion along with the prandial secretion whenever we take a meal. The prandial insulin, that is the insulin which is released after we eat food or we take meal, it is secreted in two stages. The first stage is the rapid stage, and second stage is the uh, new formation of insulin. The first stage is the rapid stage. If we see that whenever we take food, the insulin rises very fastly or it is secreted very fastly because this insulin secreted is from the pre-stored vesicles in the pancreas, and thereafter in stage 2 the insulin which is released is the newly formed insulin. So in its initial stage, first is the preformed insulin is released, and in second stage the newly formed insulin is released. The abnormality which we commonly see in diabetes is in the stage 1 of the insulin secretion, that is the first stage. So whenever we give exogenous insulin to achieve the endogenous pattern of insulin secretion is very difficult to achieve that. These are uh, the if we see the secretion of the insulin, this straight line is the basal secretion of the insulin, and these insulin surges, they are prandial surges, means this is released after we take breakfast, then this is the basal secretion, and this is released after we take meal in the lunch, and this is concerned with the uh, intake of dinner. So some amount of basal insulin is secretion is there, and the insulin which is released after we take meal is the prandial insulin secretion. As we have discussed that some amount of background secretion of the insulin is always seen in between the meals. In healthy personals, only a small proportion of the endogenous insulin which is secreted by the pancreas, it reaches the systemic circulation. For example, when the pancreas secrete insulin, it first enters the portal circulation, then it goes into a systemic circulation. So maximum amount of it first goes into the liver, approximately 70 to 80% of the insulin. This is utilized in the liver to suppress the hepatic gluconeogenesis or breakdown of the glucose, that is glycogenolysis. Only 20 to 30% reaches the systemic circulation in the adipose tissue or the skeletal muscles for the glucose uptake. This was about the endogenous insulin secretion, means the insulin which is secreted from the pancreas, it goes into the hepatic circulation, it goes into the liver, where 70 to 88% of it is utilized to suppress the hepatic gluconeogenesis or glycogenolysis, and 20 to 30% goes into the systemic circulation, means very less amount of insulin reaches the systemic circulation in the adipose tissue or the skeletal muscles for the glucose uptake. But when we give the exogenous insulin, the majority of it reaches systemic circulation first. That is, most of the insulin reaches the muscles or the adipose tissue as compared to the liver. Here, the first insulin goes when we inject it, it enters the systemic circulation. A huge amount is utilized in the skeletal muscle or the adipose tissue, and very little amount goes to the liver and to suppress the hepatic gluconeogenesis or glycogenolysis. So there is no very much effective suppression of the hepatic glucose production. So whenever we give exogenous insulin, two types of abnormalities, they are very commonly seen and they are very difficult to address. That is systemic hyperinsulinemia and portal hypoinsulinemia. The various insulin preparations which are available in the market, we have categorized into two: meal type or bolus or prandial insulins, and second one is the basal or long acting insulin analogs. The meal type or bolus or the prandial insulins, they are given just before the meals, and they are categorized as rapid acting analogs and short acting analogs. The rapid acting analogs, they act very rapidly and they are further categorized into three. In this we have insulin Lispro, the brand name is Homolog. Then is the insulin Aspart, the brand name is Novolog, and then is insulin Glargine, the brand name is Epidera. These are very rapidly acting analog. Whenever they are given before meal, their onset of action is about 25 minutes. About 25 minutes. Sorry, I would have written here hour, and this is just 25 minutes, and the action reaches peak, it's and the peak action is about half to 1.5 hour, and duration of action is 2 to 4 hour. All these are very rapidly acting, they act within 25 minutes. The peak action occurs in about half an hour to one and a half hour, and the duration of action is 2 to 4 hours. Similarly, in this meal type or bolus type prandial insulin, we have short acting insulins also. In this we have regular insulin, that is humulin, or we also have inhaled human insulin. Their onset of action is zero point 0.5 to 1 hour, peaks takes about 2 to 3 hours, and duration of action is 3 to 6 hours. So the short acting insulin or rapid acting insulin, they take very less time to act. Peak occurs within 2 to 3 hours or zero point 0.5 to 1.5 hour in case of rapidly acting analog, and the duration of action is approximately 2 to 4 hour in rapidly acting, and in short acting this is about 3 to 6 hours. Then we come to basal insulin or long acting insulin. In this we have insulin NPH. This is the intermediate acting insulin. The onset of action is 2 to 4 hours. Peak occurs in 4 to 10 hours, and duration of action is 10 to 16 hours. These intermediate acting insulin are usually given twice a day dosage. Then we have insulin Glargine, available in the market as a Lantus. Insulin Glargine concentrated form, that is U300, available in the market as a Toujeo. The onset of action is 2 to 4 hours, both these Glargines, and usually we say it as a peakless, but some sort of peak is also seen with this Glargine. We will discuss in the later slides. And the duration of action is 20 to 24 hours. So they are usually given as singles once a day doses. Then we have insulin Detemir, which is available in the market as a Levemir. Onset of action is 1 to 4 hour, and the duration of action is 12 to 24 hour. It is also given twice a day. Then we have insulin Degludec, which is available in the market as a Tresiba. Onset of action is 1 to 9 hours, and it has a longest duration of action, that is 42 hours. So coming to the these short acting insulin or rapid acting insulins, or we have already discussed that they are meal type, bolus type, or prandial insulins. They are given just before the patient takes the meal. They basically control the postprandial blood glucose levels. And in among the rapid acting analogs, they have slight change in the structure, and they vary. All these three vary very less in their pharmacokinetics. They are usually available in the monomer forms, and they are very rapidly absorbed from the subcutaneous injection site. Sorry, and when they are given subcutaneously, uh, they are rapidly absorbed. Their onset of action is just about 15 minutes to 25 minutes. So they can be given 15 minutes before meal. Their action starts within 10 to 15 minutes, and peaks takes in 2 to 4 hours. Okay, this is the rapid acting insulin, and these are insulin Lispro, Aspart, Glargine, and they are available in the market as a Humalog, Novolog, Epidera. This is the Humalog, available as a vial, and it is also available as a pen. This is Novolog, that is Aspart, insulin Aspart. Then we have insulin Glargine, that is Epidera, and we we also have ultra rapid acting or very fast acting insulin, that is Fiasp. It can be given with the meal, but it is slightly uh, costly. Coming to the short acting insulins, and this category includes the human insulins, regular insulins. They are usually available in the hexamer form. They are they are first to be converted into a monomer form or dimer form for subcutaneous absorption. That is why their onset of action is slightly delayed. That is 30 to 60 minutes. It takes 30 to 60 minutes to act. The regular insulin is available in the market as Actrapid or Hemu insulins. Uh, they are very identical to endogenous insulin polypeptide. In the solution, they are available as a hexamer form. When they are given subcutaneously, and they take about 30 to 60 minutes to act. So they should be given 30 minutes before meal. Short acting insulin can be given 15 minutes before meal, or like Fiasp, it can be given with the meal. But the regular insulin For this, we have to give them 30 minutes before meal, and their peak occurs in 2 to 3 hours. Their action actually does not mimic exactly with the physiological meal related endogenous insulin secretion. They have a delayed peak and slightly longer duration of action. So, whenever we give a regular insulin 30 minutes before meal to the patient, we have seen after meal there is early postprandial hyperglycemia and late hypoglycemia. It is because insulin takes 30 minutes minimum to act. So the blood sugar immediately after breakfast or meal, that will be high because action has not yet started. And after some time, that is after 2 to 3 hours or before lunch, there will be hypoglycemia because its duration of action is about 2 to 3 hours. So when if patient takes breakfast at 9 a.m., we have to give it at 8:30 a.m., and its peak will occur at 2 to 3 hours. And after 2 to 3 hours of food intake, the patient may have some sort of hypoglycemia, which we have to tell him so that he can take some meal or snacks. These are the few preparations of the short acting insulin like human actrapid and regular humulin, which are available in the market. Coming to the basal insulins, basal insulin, as we know that basal insulin secretion occurs endogenously in between the meals in all the healthy individuals. So the concept of the basal insulin is to give is to we have to control the basal, we have to mimic the basal insulin productions from the pancreas. So as we know, the some amount of the insulin is always produced by the pancreas in between the meals, is to prevent the hepatic gluconeogenesis. Among the basal insulins, we have two types like intermediate acting and long acting. Among the intermediate acting, we have insulin NPH. This is biphasic insulin. It is NPH means neutral protamine Hagedorn. Hagedorn was a scientist. His name was Christian Hagedorn, who discovered this in 1946. So neutral protamine Hagedorn. It is also called isophane insulin. It is a crystalline suspension of the insulin with the protamine. Protamine is a fish protein and zinc is the phosphate buffer. This property of NPH make it gradually absorbed from the subcutaneous tissue, and it is long acting. Action starts in 1 to 3 hours and it reaches peak in 4 to 6 hours, and duration of action is 12 hours. So we have to give it twice a daily basis. It is very cheap. It is available in the vial, but it is a cloudy. Before injecting it, we have to first roll it between the palms of the hands so that the cloudiness goes away. Being as it has a very lesser price, it is good to give them in the weaker section of the people. In gestational diabetes also we can use it. Advantage of NPH is that it can be combined with other rapidly or short acting insulin, and problem is we have to give it twice a day, and it definitely has a peak. So as we know, it has a duration of action about 12 to 14 hours. It has to we have to give it twice a day basis. One important problem which is seen with the patients who take this NPH is the Smogy effect. What happens in Smogy effect is that when we give this NPH insulin to the patient, for example, we give 16 units of NPH at night, the patient wakes up in the morning with history of some bad dreams or sweating, and at about 7 a.m. His blood sugar is about 500 milligram per deciliter. He goes to the doctor with his blood sugar value. Doctor increases the dose of NPH, thinking that his blood sugar is not controlled. So he will say that you, instead of 16 units as he was given in the previous night, you increase the dose to 20 units. What happens here? That when he takes this 20 units in the night, patient will have early morning, or we can say late night hypoglycemia. Late night hypoglycemia. And when this late night hypoglycemia occurs, patient may have bad dreams, sweating. Then there occurs the counter increased production of the counter regulatory hormones, and this counter regulatory hormone causes increase in the blood glucose production, that is early morning hyperglycemia. What happens in smoky effect is patient have early morning hyperglycemia because of rebound effect of the late night hypoglycemia. Patient initially, when at about 2 to 3 a.m. in the night, he has late night hypoglycemia. When this late night hypoglycemia occurs, there occurs rebound or increased production of the catecholamines, and these catecholamine increases the blood glucose level, and patients has early morning hyperglycemia. So this is the basically a smoky effect. To So the doctor will, if a doctor doesn't know about this, he will increase the dose of insulin. The patient can have late night hypoglycemia, and it can lead to death. So to prevent this effect, we have to tell the patient about its side effect, that patient can have a late night hypoglycemia. So we will say that to take snacks before going to the bed. If he misses the snack, then this the peak of NPH, especially the patient has, अगर उसने if he hasn't taken the snack before going to the bed, then there are very likely chances of hypoglycemia in the late night, that is about 2 to 4 a.m., and the high risk of hypoglycemia. Then after hypoglycemia, there will be rebound hyperglycemia due to counter-regulatory hormone, which will lead to the early morning hyperglycemia. So the treatment of the smoky effect will be the reduction in the dose of NPH, not to increase the dose. If we increase the dose, we may send the patient in the jaw of death. So whenever the patient comes with typical early morning hyperglycemia, first thing which should come in our mind, that is nocturnal nocturnal hypoglycemia, and we should decrease the dose of NPH, and we should always tell him, if he is on NPH, to take the snacks before going to the bed. As this smoky effect, because of smoky effects or late night hypoglycemia, uh, we brought new product in the market, that was Glargine. This is a long acting insulin. So in among the long acting insulin, uh, we have insulin Glargine, which is available in the market as a Lantus. Insulin Glargine U300 Toujeo. It is a concentrated form of Glargine. Then we have insulin Detemir. It is available as a Levemir, and insulin Degludec, that is Tresiba. Glargine is a long-acting insulin, and it is available as a Lantus or the Toujeo. It is only acidic insulin, and it can be mixed with any other form of. It can't be mixed with other insulins. It forms aggregates in the subcutaneous tissue, which leads to slow dissociation. So it acts for 24 hours. OD dose is possible with the Glargine. Initially, some physician thought that it is peakless. Some said it has a peak. To overcome this problem, the concentrated form of Glargine, that is U300, that is Toujeo, was brought into the market. Now it is proven that whether we give Glargine or U300 Toujeo, there is some peak with the basal insulin, that is Glargine. So it does not act for 24 hours. It acts for 18 to 20 hours. So there is likely chance of 4 hours of hyperglycemia, and this is called dusk phenomenon. And to deal with the dusk phenomena, we prepared the concentrated form of Glargine. Routine Glargine has 100 units per ml of insulin, and this Toujeo or concentrated form of the Glargine has 300 units per ml. The company which makes the Glargine U300 or Toujeo claims that it acts for 24 hours. So OD dosage is possible with this Glargine insulin. Then we have insulin Detemir. It is also a long-acting insulin, controls the basal secretion. It controls the fasting blood glucose levels. It is given. It has a duration of action as 12 to 18 hours. It has to be given twice a daily dosage. In this insulin, some sort of amino acid fatty acid group is added to beta chain, which makes its binding possible with the albumin in the subcutaneous tissue, and this albumin binding delays subcutaneous absorption. Peak effect is less, hypoglycemia is less with Detemir as compared to NPH. It is also given twice a daily dosage. Duration of action is not as good as Glargine, so its action duration of action is 12 to 18 hours only. Then we have the insulin Degludec. It is a ultra long acting insulin. It forms multi-hexamer aggregates in the subcutaneous tissue. It has a half-life of 2.5 to 4 hours. It has a peakless basal profile and its duration of action is about 42 hours. It can be injected once in a 24-hour and we can have the flexibility of variable timings. With Glargine, we have to follow the strict timing that if we give it at 10 a.m. or 10 p.m. in the night, we will give it in the 10 p.m. or 10 a.m. in the night only. But with Degludec, we can take this much liberty with the flexibility dosage timing in the 24-hour. It can be taken any time of the day, but problem with the Degludec is that if we take it at the same time daily, that is for example at 10 p.m. daily, then there are chances of insulin stacking, which may increase the risk of hypoglycemia. It is very costly, available in the market as a Tresiba. There are some pre-mixed insulins available in the market, and these are conventional pre-mixed insulin and pre-mixed insulin analogs. Conventional pre-mixed insulins are regular insulins and the combination of the regular insulin and the NPH, and the pre-mixed insulin analogs are available as in the form of, let's discuss about the conventional pre-mixed insulin. They are available as 30-70 combination, 50-50 combination, 25-75 means 30% regular insulin and 70% of the NPH. 50-50 means 50% of the regular insulin and 50% of the NPH, and 25-75 means 25% of the regular insulin and 75% of the NPH. NPH is the intermediate acting and these are the short acting insulin. Again, we have pre-mixed insulin analogs like Humolog mix, that is 75-25 means 75% insulin Lispro protamine and plus insulin Lispro 25%. Then we have Humolog mix 50-50, 50% insulin Lispro protamine and insulin Lispro 50%. Then we have Novo mix 30-70 insulin Aspart 30%, 70% insulin Aspart protamine. Then we have Rhizodec 30-70, 30% of insulin Aspart, that is a short acting, as 70% Degludec, that is a long acting. And these are the few brands available in the market of these pre-mixed insulin analogs. The only advantage of the pre-mixed insulin is that uh, we can give lesser injection. Disadvantages are the fine tuning not possible. We have to follow strict meal pattern, not feasible for the children. Patient can have a nocturnal hypoglycemia, may need diet change for insulin rather than insulin change for diet. They can't be used in type 1 diabetes. We have to follow this 3 meals, 3 snacks must be there for if patient is under premix insulin. As we have discussed about the types of the insulin, we know it is what are the indications for the insulin. It is the type 1 in diabetes mellitus, secondary diabetes mellitus, that is secondary to pancreatitis, steroid induced, gestational diabetes mellitus, especially if the targets are not achieved, acute diabetic complications, type 2 diabetes mellitus where there is primary or secondary oral anti-diabetic failure at the beginning of the type 2 diabetes or initially, and if not responding to the three drugs, patients in type 2 diabetes with acute stress, for example surgery, trauma, patients of chronic renal failure with diabetes, we have to better to keep them on insulin because of risk of hypoglycemia. Use of parental nutrition, weight loss more than 10% body weight, and here we can use the insulin. In type 2 diabetes, the counseling for initiating the insulin should be done from the beginning, and in every visit he should be told that he is going to need insulin in the future. How to start the insulin? uh, Two types of regimes or therapies are available One is the augmentation therapy, second is the replacement therapy. In augmentation therapy, the patients who are already on the oral antidiabetic drugs in type 2 diabetes, we want to augment the glycemic control. Our patient has a glycemic failure with oral antidiabetic drugs. Patient has some residual or insufficient beta cell function. So we start with the basal or the bolus insulin depending on the fasting or the postprandial hyperglycemia. We usually start with the zero point 0.3 units per kg of the insulin. Our range is zero point 0.1 to zero point 0.3 units per kg. And in replacement therapy, this is given in the patients who needs intensive glycemic control. For example, in type 1 diabetes or advanced type 2 diabetes, or those who have failed augmentation therapy. Here we can use basal bolus regime plus correction, and we start with the zero point 0.6 to 1 unit per kg of the insulin dose, especially with the type 1 diabetes. And in type 1 diabetes, we can start with the zero point 0.5 units per kg of the insulin. And so these insulin regimens or replacement therapy for type 1 diabetes can be conventional regimen, like they are less costly. Here the fixed dose of NPH twice daily plus fixed dose of short acting insulin like BD or twice days TDS basis are used. This is especially for the weaker section of the people. Then we have intensive insulin regimes, basal bolus regimes to meet the physiological basal and the bolus insulin secretion. For example, Glargine at night and regular or short acting insulin every before every meal. Then we have continuous subcutaneous insulin infusion pumps. They are given by the insulin pumps. We have modified insulin regimes like at breakfast. Before breakfast, we give insulin NPH and rapid acting insulin. At dinner, we give insulin Glargine or Detemir plus rapid acting insulin. And this modified insulin is not advised because it increases the glycemic variability and there is risk of hypoglycemia. So, in type 2 diabetes mellitus, whenever we if we want to give the insulin, first of all we have to see what is the dose of insulin required for that patient. For example, whatever dose we have calculated, the we have to give 40 to 60% of the insulin as a basal insulin and 40 to 60% as a prandial insulin. Basal insulin is usually given as Glargine, Detemir or Degludec, and prandial insulin they are given before meal or snacks, and they are available as a short acting or long acting insulin. So in prandial insulin we usually use rapid acting insulin like Lispro, Aspart, glulicin. They can be given 15 minutes before meal. And daily dose for children diagnosed with type 1 diabetes, uh, in these children, the dose of insulin is zero point 0.3 to zero point 0.5 units per kg. In prepubertal children, the dose is zero point 0.3 to zero point 0.7 units per kg per day, and pubertal children, it is zero point 0.7 to 1 unit per kg. And as also in the patients with obesity or ketoacidosis. And the dose of insulin can be titrated up or down depending upon the response. Basal insulin they are usually given once a day, but in some children they do better with the two divided doses. So those who tend to have nocturnal hypoglycemia or when detamir insulin is used. Insulin degludec may be used as it has a very longer duration of action, but uh, it is used as a once a day dose. Just example, if we have calculated that 30 units of insulin is required for a person, then basal requirement will be 40 to 60%. That is about approximately 15 units. And in the prandial insulin, again 40 to 60. Suppose it is 15 units. So for basal insulin, we can give as a glargine as a 16 units once a day, or NPH 8 units. BT, these are the basal insulin, and the prandial insulin can be further divided into before breakfast, before lunch, and before dinner as 555 units. So in type 2 diabetes, more than 50% of the type 2 diabetes patient will require insulin in their lifetime, and in Indian setting, it is approximately about 90% of the type 2 diabetes patient will require the insulin. So the first line treatment for type 2 diabetes in whom we want to start the insulin is the Glargine insulin, basal insulin, and Glargine U100 or 500 or Degludec, they can be used. As we know that in type 2 diabetes there is no insulin deficiency, beta cell function is reduced, and some reservoir is present. The first preference in these cases is basal only insulin, and if it does not work, then we can go into the second line regimen, and the second line regimens are the pre-mixed insulin regimens like in BD or twice days, like 30 70 50 70 and Novomax like Dex. They can be used, or we can do use basal bolus regimens or basal plus mealtime regimen, one or two probably. So in type 2 diabetes, if we have to start the insulin at a bed time or in the morning, usually we give at night time. It should be started with the 10 units. It means insulin glargine or the long-acting insulin should be started with the 10 units, or we can say in a, a zero point 0.1 to zero point 0.4 units per kg. Sometimes we can use higher dose also if the patient is very obese, and when we give basal insulin, then the target is the fasting glucose, and over target for fasting glucose is 80 to 120, or we can say 130 milligram per deciliter. And till we achieve this target, we go on increasing the dose by 2 units every third day. And in some cases where the fasting glucose is very high, for example it is more than 180 milligram per deciliter, then when we can increase the dose by 4 units every third day. So we have to keep on increasing the dose by 2 units every third day till we achieve the fasting glucose level of 80 to 120 or 130 milligram per deciliter. If hypoglycemia occurs or fasting blood glucose level decreases beyond decreases below less than 80 milligram, then we have to reduce the dose by 4 units or 10%, whichever is the lesser. If HbA1c becomes less than 7, then continue the same units and check blood glucose every 2 to 3 months. If HbA1c is still more than 7 every 2 to 3 months, then the fasting glucose is in the target range. Then we have to check his pre-dinner, bedtime or pre-lunch blood glucose, and we have to add second injection, that is rapid acting insulin. We can begin with the 4 units and adjust by increasing 2 units every third day until the blood glucose in the range. If pre-lunch glucose is out of range, then we can add rapid acting insulin in the breakfast. If the pre-dinner glucose is out of range, then we can add NPH insulin at the breakfast or rapid acting insulin at the lunch. And if pre-bed glucose is out of range, then we can add rapid acting insulin at the dinner. So after doing all these things, we will check HbA1c again in 2 3 months, and if HbA1c is less than 7, then we will continue with the same treatment, and if HbA1c is equal or more than 7, then we will have again need to recheck the pre-meal glucose level, and if it is out of the range, then we may need add another injection of the insulin and check HbA1c, and if HbA1c is still out of range, then check 2 hour postprandial glucose level and adjust the preprandial short acting insulin. This thing occurs with the practice. As we go on using this method in the practice, we can easily control the blood sugar of the patient. So insulin can be given with metformin, there is no problem. But when we use insulin with insulin secretagogues like sulfonylureas, we have to explain the risk of the hypoglycemia to the patient. Insulin can be given with pioglitazone, but there are chances of weight gain, and if the patient is in the cardiac failure, it can worsen the cardiac failure. Insulin can be given with DPP4 inhibitor, SGLT2 inhibitors, there is no problem, we can use. So the insulin is given to the patient in the subcutaneous tissue by either by the insulin syringe or insulin pen. It can be given as a intranasal insulin or continuous insulin or continuous subcutaneous insulin infusion devices. The insulin syringes, they usually come in two forms, like 40 units per ml and 100 units. The 40 units per ml insulin syringe comes as a in with the cap of red, and the 100 units per ml insulin comes with the cap of gray color. It comes in the gray color. So whenever we give insulin to a patient or a lady, then we have to be very uh, if we are giving insulin, this U100, then we have to give it with the syringe which which is marked as 100 units. Don't mix it. We don't give insulin U100 with the insulin syringe which has 40 units. Okay, it is this insulin U40 is red in color. It comes under government supply. U100 syringe is for U100 insulin only. Don't use U40 for U100 insulin, or U100 syringe for U40. So you have to use U40, U100 syringe for U100 insulin only. It is always ideal that insulin syringe should be broken after single use, but because it little bit get bent at the bevel end, and it causes lipoatrophy, which further leads to fibrosis and decreased absorption of the insulin. uh, but being a developing country, and if we see the patient's requirement, he can use it for at least three uh, three three times, or maximum 5 times, and thereafter he should discard that insulin syringe. And as the patient can discard the insulin syringe also when it causes pain. The insulin which comes in the cloudy preparation, especially the NPH insulin, we have to first roll it between the hands, then wipe it with alcohol swab, and usually insulin is given in the abdomen or anterior lateral aspect of the thigh, backside of the forearms. In abdomen, the absorption is very good, and the same side should not be used daily, and the injection which is given at one side, it, it should be given on that side after 2 weeks. So we have to rotate. In my next lecture or next video, I will talk about the how to preserve the insulin, how to give the insulin, what are the various sites where the insulin can be given, how do we have to rotate the sites, and how can we uh, make the patient aware about the uh, use of insulins. So these are the various insulin syringes, insulin pens, inhaled insulin, and the continuous subcutaneous insulin infusion devices through which we can give insulin to the patient who are living with the diabetes. This was about the insulin. In my next video, I will talk about the storage of the insulin, how we deliver insulin by insulin syringe or with the pen, or how does the continuous infusion insulin infusion pump works, what are the uh, what are the things which are to be told to the patients, their relatives, how do they have to store the insulin, and what are the risk of hypoglycemia, and what are the precaution the patient has to take when they are on insulin. And all these things I will discuss in my next video. Thank you very much.